Hi, thank you for tuning in. My name is Jasper Vleugels and I am a research fellow at the Academic Medical Center in Amsterdam, the Netherlands, and I'm working together with Professor Evelien Dekker. In this video I would like to discuss our recent article in Gastrointestinal Endoscopy, titled Endoscopic detection rate of sessile serrated lesions in Lynch syndrome patients is comparable to an age and gender matched control population. The subtitle refers to the design of the study, which is case control study with expert pathology review. Some background information. Patients with Lynch syndrome are at increased risk for developing colorectal cancer due to a germline mutation in one of the mismatch repair genes. Patients with Lynch syndrome therefore undergo annual or biannual colonoscopy surveillance to detect colorectal cancer in an early stage and to prevent the development of colorectal cancer by removing polyps, which are presumed to be the precursor lesions of colorectal cancer in Lynch syndrome patients. It is assumed that all these colorectal cancers in Lynch syndrome patients arise from premalignant adenomas. However, during the last decade, in the average risk population, the occurrence of colorectal cancer is also increasingly linked to the serrated neoplasia pathway. In this pathway, sessile serrated lesions, which are usually difficult to detect during colonoscopy, develop to colorectal cancer. Possibly, some of colorectal cancers in Lynch syndrome patients can also be attributed to the serrated neoplasia pathway in Lynch syndrome. Increased detection rates of sessile serrated lesions with or without dysplasia would maybe suggest that the serrated neoplasia pathway may play an additional role in the fast colorectal cancer development in Lynch syndrome patients alongside the adenoma-carcinoma sequence. However, to this date, the prevalence of sessile serrated lesions in patients with Lynch syndrome is unknown, and the aim of our study was to determine the endoscopic detection rates and distribution of sessile serrated lesions in Lynch syndrome patients and to compare this to an age and gender matched control population. To investigate this, we performed a case control study with Lynch syndrome patients from two tertiary referral centers, the Academic Medical Center and the Dutch Cancer Institute, both situated in Amsterdam. We selected Lynch syndrome patients with proven germline mutations from pre-existing lists and matched these to age, sex and colonoscopy indication to patients from an outpatient colonoscopy center. All serrated polyps that were resected during colonoscopy of these patients, with the exception of diminutive hyperplastic polyps resected in the rectum and sigmoid colon, were retrieved and reviewed by two specialist pathologists who were blinded for the initial diagnosis and location of lesions. As a result, we could determine true prevalence rates of sessile serrated lesions and compare these between groups. Then we move on to the results section. From our list, we matched 223 Lynch patients to 223 controls that underwent colonoscopy between 2011 and 2016. Sessile serrated lesions were detected in 7.6% of colonoscopies performed in Lynch syndrome patients compared to 6.7% of controls, without a statistical significant difference. High-risk sessile serrated lesions, which were defined as sessile serrated lesions larger than 10 mm in size or those containing dysplasia, were detected in 1.8% of Lynch syndrome patients compared to 0.9% of controls. None of the detected sessile serrated lesions in Lynch patients contained dysplasia. In regression analysis, increasing age was associated with increased prevalence of sessile serrated lesions. There was also no increased risk of synchronous or metachronic advanced neoplasia when a sessile serrated lesion was detected. To our knowledge, our study is the first study that assessed sessile serrated lesion detection rates in a large population of Lynch syndrome patients. However, the results of our study are not so easy to interpret. The detection rate of sessile serrated lesions in Lynch syndrome patients seems not to be increased compared to age and gender matched controls. From a clinical viewpoint, this would imply that during colonoscopy surveillance of Lynch syndrome patients, sessile serrated lesions should be detected at comparable detection rates as those reported in the average risk population. Also, none of the detected sessile serrated lesions contain dysplasia. Therefore, we also believe that the findings of a study seem to suggest that the serrated neoplasia pathway seems to play a similar role in colorectal cancer development as in the general population. Future studies should perform molecular analysis on all serrated polyps in Lynch syndrome patients to further explore the potential role of the serrated neoplasia pathway in Lynch syndrome colorectal cancer development. This was what I would like to discuss, and I would like to thank you again for tuning in and watching this video. Bye!